Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Anna Malvar in Buenos Aires, Argentina, and Professor Brett Rovin in Columbus, Ohio, with whom we would like to discuss the use of the type 2 monoclonal CD20 antibody Obinutuzumab in active lupus nephritis, focusing upon their REGENCY study that has been published in New England Journal of Medicine a few weeks ago. Dear Anna, dear Brett, we are blessed to host you tonight.
Dr. Anna Malvar is a consultant nephrologist at the Hospital Fernandez and the Organización Médica de Investigación in Buenos Aires, Argentina. And Dr. Brett Rovin is the Lee A. Herbert Professor of Nephrology at the Ohio State University Wexner Medical Center. And we are very glad to have you actually presenting some data of the REGENCY trial tonight.
Great to be here. So what we'll start out with is the presentation of the data from the REGENCY trial that we gave in India at the World Congress of Nephrology. And then hopefully as we go through the slides and questions come up or interesting points come up, please, sort of ask Anna and myself to comment on those things, and we can have a robust discussion. So these are the disclosures that we presented. So I think everyone in the audience knows that lupus nephritis has a lot of unmet medical needs. It still remains an important cause of end-stage kidney disease, despite the new therapies that we have. We know B cells are central to the pathogenesis of lupus nephritis, not just because of the production of autoantibodies, but also by a lot of trials now that have shown elimination of B cells has had a profound effect on the disease response. And a lot of these trials were started, of course, by George Schett in Erlanger. So also well known is the fact that our first attempt at eliminating B cells with an anti-CD20 monoclonal antibody, rituximab, failed in the LUNAR trial many years ago, which was a little discouraging. But some of that may have been due to rather incomplete B cell depletion with rituximab. And so we postulated that a better depleter of B cells, like obinutuzumab, might actually have better results. One of the things that's important to note is that in the LUNAR trial, when we did a post-hoc analysis, we did see that the patients who B-cell depleted actually did show a signal for remission. And so that was the premise leading up to using obinutuzumab. And we'll go over obinutuzumab now. Obinutuzumab is called the type 2 anti-CD20 monoclonal antibody. It's fully humanized as opposed to rituximab. And it's been around for a while for use in lymphoma and leukemia. And we know that in tissue sites of these malignancies, we have better B-cell depletion with obinutuzumab. It's a better killer antibody because of the way it was engineered. As you can see in the figure or the representation of the antibody, this FC region was glycoengineered, and that increases its antibody-dependent cellular cytotoxicity. And then this antibody binding conformation is really important because it doesn't necessarily require complement to cause cell death, which is really important in lupus when we have a lot of our patients with active nephritis complement depleted. The other thing that's important to remember about this type 2 antibody is that it is not taken up as readily and internalized, which is one of the problems with rituximab. So it eliminates the antibody fairly quickly. And so for all these reasons, it seemed like obinutuzumab would be a good antibody to look at in the lupus nephritis trial. We did this in the phase 2 NOBILITY trial. Anna and I both participated in this trial. And what you see here is that starting at week 52, the patients in the obinutuzumab arm compared to the patients in the standard of care arm, which was mycophenolate plus glucocorticoid plus placebo versus obinutuzumab in the drug arm. You can see that there was an advantage giving obinutuzumab. This stretched to an effect size of 20% by week 76, and this reached statistical significance. And this was maintained up to 2 years. And it's important to remember that the doses of obinutuzumab ended at 1 year in this study. Really, a dose at the beginning and a dose at 6 months. And there were really tolerable, a very tolerable adverse events profile, really quite comparable to the placebo arm. This is the highly complicated pairing schematic of the REGENCY trial that we'll discuss in detail now. We have data up to the primary endpoint, so this is week 76. Just so everyone knows, the trial will continue on for quite a long time for patients who were doing well, and they'll maintain their blind. And then patients in the various groups who did not do well, primarily the placebo group, can now go into the open label and receive obinutuzumab. So again, we'll have a lot of information over a longer period of time of how obinutuzumab works in our population. In any case, patients were randomized 1-to-1 to receive obinutuzumab or placebo. Placebo, of course, was mycophenolate plus glucocorticoid plus a placebo infusion. Obinutuzumab was the same standard of care background. And then patients were divided 1-to-1 into a group that received 2 infusions at weeks 0 and 2, 2 infusions at 6 months, and 2 infusions at 52 weeks. And then at 76 weeks was the primary endpoint, which was complete renal response. Arm 2 received the same infusion schedule, except 1 fewer infusion towards the end of 1 year. The complete renal response endpoint was pretty rigorous, less than 500 milligrams a day of protein, a GFR that had to be within 85% of baseline, no use of rescue therapy, no intercurrent events like treatment failure, death, or study withdrawal. And we also looked at secondary endpoints, reducing glucocorticoid dosing, change in GFR, and flare rate. And I'll show you some of those data in just a minute.
May I interrupt you here for first time, since you asked us to interrupt you? Is there any underlying reason for this scheme giving 2 dosages a fortnight apart? So why can one not just go with 2 grams at one time and then say 5 months or so later the second dosage?
So part of the idea was if we gave the 2, and 2, would we get better B cell depletion within the tissues? That's really not clear. That was sort of a thought in formulating the trial design. What we can tell you, although we can't share the data with you right now, is that we did, and Anna can talk more about this, and she did the bulk of these, we did do repeat biopsies prior to the trial, to enter the trial of the kidney, and then at week 70, at or around week 76. And so I think it's going to be very exciting to look at the change in the B cell profile of the kidney tissue to sort of understand if obinutuzumab is doing what we expect it to do, eliminating B cells in target tissues.
So may I just follow up with a question also for Anna? How many patients did have sequential biopsies? So I guess not all of them, right?
No, the rebiopsy at week 76 was optional, and now we are performing the study of all these rebiopsies, and they are 70 patients. They are going right now under study, so we do not have the final results. But as Brad said, it will be amazing to see if, first of all, if there's any difference in the activity index. I don't know if in the chronicity index there will be any difference because perhaps it's too soon, but probably we'll see something. And then see if 1 gram is the same as 2 grams when they are given after 12 months of treatment. But the results are just now being studied. So, but it is very interesting because it's the first trial, one of this kind, that will have such an amount of patients that were rebiopsy.
Yeah,
This
7
is
is a great number, I would say.
Yeah, this is really good because as it turns out, about half the patients were placebo group and about half the patients were Obinutuzumab group. And I think this will be very exciting. Anne and I have anticipated this for a long time. One of the things that we hope is that we'll have these data available for the ASN meeting in the fall, so that we can bring these out to the nephrology community. So stay tuned for that. I think we did repeat biopsies in the voclosporin trial, but they were a handful compared to this trial. So I think we'll get quite a bit of information from these repeat biopsies.
One more question here, and then I will mute myself. So in the follow-up part for the patients who remain blinded, you will continue to give the medication independently of their B cell counts, independently of other markers. They will just receive further treatments each, say, 26 weeks or so.
This is the design, and we can talk about this because it's a really important question. And, obviously the same question came up in the ANCA literature when we started using rituximab as a maintenance therapy for really a long time. Do we dose by schedule or do we dose by B cells? These folks are going to get every 6 months 1 gram going forward for the length of time you see in front of you. And that's a lot, maybe. I dose, now I've been using OB when I can get it, not for lupus because it was under trial, but I've been using OB like many other people for lots of different antibody-mediated or antibody-involved kidney diseases. And I actually, after the first couple of dosing, I check B cells. B cells are profoundly depleted for a really, really long time in other patients with kidney disease. And so we have adopted in our unit to look at B cell counts before we redose. I think this is something that has to be explored when this drug is available to the community, so we learn how to use it correctly and for safety purposes as well.
So
Yeah,
in
go
the
ahead.
repeat biopsies, are you doing other investigations rather than AI and CI, like single cell transcriptomics to look at B cell profile as well?
Well, no,
We hope to.
yes, we want to, not yet. Now we are just studying the histological changes, but the idea is to study at the molecular level what's going on. That I think that's the most important thing.
Yes.
What we hope to do instead of single cell RNA-seq, which of course involves disrupting the tissue, the techniques now for spatial transcriptomics on FFPE tissue is very, very good. We're doing FFPE in the AMP-AIM program, and Anna and I are doing this with one of our collaborators at University of Washington with her repeat biopsy set. And so we would rather probably do, and what we've proposed to the company is to do spatial transcriptomics to look at sort of the molecular changes in the biopsies over time.
Yeah, perfect.
Yeah,
Very important.
yes, in lupus nephritis, the environment is quite important. So the spatial technique is great.
It's expensive, but it's worthwhile pursuing, especially in a clinical trial like that.
It is expensive, but maybe very inexpensive compared to the cost of doing the clinical trial. And then, of course, if it informs us down the road, I think it'll be worth it's worth the cost.
I think so. Good.
So anyway, these were the inclusion and exclusion criteria. So I'm gonna talk about the inclusion criteria, and then I think it does deserve some discussion. I'll leave it to you to guess what the discussion is. But anyway, this was restricted, and I'm framing it that way so it motivates the discussion. Restricted to class 3 and 4 lupus nephritis, plus or minus class 5. We did not enroll patients with pure class 5. They had to have a kidney biopsy performed proximal to starting the study. So what do you think about that? There's been a little bit of criticism of not including pure class 5.
Well, I think you are the expert, but it is very important also to get information on class 5, because you're also in the KDIGO guidelines, as you know. I mean, there's a bit of paucity on real good options for class 5 or solo class 5 cases, I would say.
It would have been excellent to include them, thinking about the pathogenesis of lupus and how these drugs act. Probably they would have do well, and now we would have results so as to class this class that it is orphan when we decide what to do, and we think that it is just the same as the proliferative or the combination. And when we rebiopsy patients, what we see is their proliferative lesions disappear quite fast with MMF, and membranous or class 5 is still there. And sometimes patients still have proteinuria, even though the activity index is 0. So proteinuria means that class 5 is still active, though the proliferation lesions are out. So I would have loved to have class 5 included.
Yes.
So let me try and justify. I agree with what you said. We have very little data on class 5, but again, this was a phase 3 trial to get a drug approved. And my contention, and I think we learned this from the Belimumab trial, the Bliss-LN, and the voclosporin trial, if you don't focus on class 5, what you can wind up with is, and we all know the tempo of remission in class 5 is quite different than proliferative disease. If you don't give it long enough and you don't have a sufficient follow-up, you can get misled, just like Anna said, with ongoing class 5, but you've taken care of the proliferative lesion. You wouldn't know that without a repeat biopsy in those patients. So I don't want people to walk away from this trial under the impression that we don't think that this drug could work in class 5. I think class 5 deserves its own trial. I think that way we can enrich, because both in the voclosporin trial and the Bliss-LN trial, the number of patients with class 5 was pretty small, but in neither of those trials was the result significant for class 5. Now, you can say, well, Belimumab had 2 years and it could have and should have been significant. Maybe so, voclosporin, of course, we use calcineurin inhibitors for membranous nephropathy of other causes, right? But the voclosporin trial was 1 year, and it didn't reach statistical significance. So again, whether the drugs are good or not for class 5, they should be tested in a class 5 population. It's different enough clinically that I think it deserves its own trial. And I would suggest that we pursue that. We will get some information from the mixed classes here, certainly, but I think that it's important that we don't jeopardize registrational trial of a drug when it is working, but it takes a longer time for a specific class to resolve. The key exclusion criteria is highlighted. The GFR is less than 30. All the other exclusion criteria are pretty typical of lupus trials now. Baseline demographics are listed here. As you can see, we did try to have an ethnically and racially diverse population. I think we heavily succeeded on Hispanic or non-Hispanic ethnicity. As you can see, half the patients were of Hispanic ethnicity, thanks primarily to Anna, I think. And we did enroll about 11 to 12% of African ancestry patients. And then stratified, as you can see, mostly women as expected. GFR was pretty well preserved in both of the cohorts or arms, and significant proteinuria in the placebo group and the obinutuzumab group. So this is the primary endpoint, and we can discuss this a little bit. Remember, the primary endpoint criteria are listed in this box on the left. And then this was a significant treatment difference with an effect size of about 13.4% in favor of obinutuzumab at week 76. So this was the first time a anti-CD20 monoclonal antibody met its endpoint as originally designed. So, any discussion here?
Well, I was surprised a bit by the huge confidence interval of the results. But again, I think coming a bit back to the class 5 discussion beforehand, I think Roche Genentech took a huge risk not to include more than 300 patients, because it's from the approval trials, it's the smallest one. So I was a bit surprised not to see more patients in the trial, because that's a risky business, as you know.
So as I do more and more of these trials over life, I'm actually surprised any drug gets to an endpoint and reaches an approval level. So many things can become unusual in a trial, and certainly in this one as well, which we'll get to shortly.
But I think, I mean, the difference is striking, which is important. But also, if we come back to the Luna discussion, we also had a delta of 11%. And here we have a delta of, I don't know, 13%, right? And the endpoint was, I think, in Luna, 52 weeks, right? So it's interesting to see that there is, numerically, it's not a huge difference. But I mean, of course, with more patients in the trial, it's easier to get a robust signal.
So this delta was smaller than we expected.
Ouch.
I think we can say that with confidence. Compared to what we saw at week 76 with the NOBILITY trial, where we saw an effect size of about 20% that was maintained from week 76 to the 104 week endpoint without any further doses of obinutuzumab. And I think we do have an explanation, and it's a strange explanation, but I'll show you this in the forest plot, which we'll get to fairly quickly. But in this trial, even though the majority are women, 66% of the men who were in the placebo arm responded with complete renal response. That's unprecedented in anyone's experience, right? I mean, it just, and we've analyzed these data and looked at the data, and we cannot figure out what was unusual about this group of men with lupus nephritis. But as you'll see when we get to the forest plot, if you remove the men and look at the results in the women, the difference between placebo and the obinutuzumab arm was 20%, which is much more along the lines of what we expected as an effect size. I have no explanation for the men. Anna, any comments on that?
No, not at all. It was widely discussed, do you remember, Brad?
Yes.
I don't know what happened with these men, because that's not what we see. Well, you're studying what's going on with men versus women, and you see that there's not, as we used to say, that there's a huge difference among them. But this study was quite unusual. I don't know.
Yeah. What Anna's referring to is we pooled a bunch of data, and we took data from the placebo arm of several clinical trials just to look at the question once again with well-characterized men versus women. Do men really do worse with lupus nephritis? And by and large, we didn't see that to be the case, but they didn't do better. And this was exceedingly better than anyone would have expected. So that was, that's why I say it's amazing to me that any clinical trial reaches its endpoint. Here is a well-designed, well-executed clinical trial, and here you have an aberration of the vast majority of men having a complete renal response with standard of care therapy. Totally unexpected and impossible to account for statistically or otherwise. So I think that's a little bit of an explanation for the effect size. And we'll see, how this shakes out when we start using it. But those of us who use the drug sort of for other diseases have been pretty impressed with how well it actually does work, male or female.
What did you expect actually as CRR across both genders? Because to me, 33% for people who actually receive current gold standard treatment with mycophenolate and steroids looks rather poor. And when looking upon kind of the other data that you showed, there was merely a slight rise in complement levels in the so-called placebo group, again, which is actually gold standard, and a fall in anti-double strand DNA antibodies, which is rather short-lasting. So did you expect this 30-something%, or was this lower than considered when designing the study?
No, I think when designing the study, it was being powered based on sort of what the placebo arms of the other studies, similar studies had been. And as you recall, the placebo arms of the other studies were in the 30%, 25 to 30% range. Now, I would say that probably in your practice as well as mine and Anna's, that when we treat patients with standard of care, and let's just standard of care being mycophenolate and steroid, the patients really do a lot better than what we see in clinical trials because, the definitions are so rigid in a clinical trial. When we're taking care of people in real life, we look at how they've been doing and then how they change when we treat them. That's how we decide how well they're doing. And here, that information is not usually part of the trial. So it again points out, that real world experience is going to be quite different, I suspect, than what we see in a trial.
The same we see with rituximab. One thing is the lunar study, and other thing is what we are doing in our daily practice and the results we see with rituximab.
Yeah. So I think what we have to, the great thing is with a positive trial, we can hopefully get these drugs available to use out in the community. And what we have to do as custodians of these drugs is sort of record what happens when we have these drugs in these real world trials that a lot of the companies are putting forward now. My suspicion is we'll see that these work much, much better. We know, for example, we know a patient that has had damage in the past and proteinuria is never, ever going to reach a CRR defined rigidly in this trial, right? Because they already have proteinuria. So it's not going to magically go away. So if we can control them, we're really happy and the kidneys do well. So I think we have to think about all those things when we finally evaluate a drug over many years of having it out in the community. You can see that OB makes B cells go away very well. I thought to myself, I had not encountered anyone who had not completely gotten rid of their B cells in my practice until about a month ago, when I met a patient who had 2 grams of obinutuzumab and she did not fully deplete. So there are some patients that require a little bit more, but most patients deplete and stay depleted for the entire duration of time that they're receiving obinutuzumab. These are the changes in complement, and these are the changes in double-stranded DNA that I think Gunnar was talking about. These are mean changes, and I think what everyone wants to see is actual values. And I think in the post-hoc analyses, we will give actual values of the course of proteinuria, the course of the double-stranded DNA and the complement levels. I think those granular data are quite important in helping us understand how the drug's working. The key secondary endpoints were set up on a hierarchical scale. And so you can see here that starting with complete renal response at week 76 with a prednisone taper, that was in favor of obinutuzumab and reached statistical significance. The proteinuric response, getting urine protein less than 800 milligrams a day, was favored in the obinutuzumab arm, and that was statistically significant. The mean change in GFR may be too soon to look at week 76, but the obinutuzumab group actually had an improvement in eGFR, and the placebo group had a decline in eGFR. That didn't reach statistical significance, so that was the end of being allowed statistically to look at significance in the other endpoints, but secondary endpoints. But what you can see here is death or renal related events was much higher in the placebo group numerically. Overall responses were about the same in both groups. That's a partial response as well as a complete response. And there was no improvement in the fatigue score, which was measured by the FACIT tool. These were the intercurrent events in the intention to treat population. And you can see that there were more events in the placebo group. What I wanted to point out here is sort of the treatment failures. The treatment failures were not because patients went on dialysis or developed end-stage kidney disease. Very few of them did. But these were failures that were worsening of the lupus nephritis. And you can see almost a 3- to 4-fold increase in the placebo group. So I think this is important. And it sort of will support the data we have on flares later on. This is the flare data, and you can see that from 6 months forward, we looked at flares of lupus nephritis, and you can see that, well, there were very few flares over the entire population. You can see that the number of flares was about twice as many in the placebo group as in the obinutuzumab group. Now, I think when we extend the data longer, we'll have very, very good data on how OB does in keeping flares under control. Hopefully, it will bear out over time. These were the unfavorable kidney responses, and again, most of these were due to treatment failures or doubling of serum creatinine. So you can see almost a threefold increase in these adverse events in the placebo group. And of course, this was the directionality of the GFR changes. Now remember, this wasn't a slope. This was the GFR at the beginning and the GFR at week 76. What we want to do is look at the population over 2 years or more and do the GFR slopes like we did in that we're doing in the IgA trials and we did in the NOBILITY trial. And so that will be forthcoming over time. This is the subgroup analysis. So you can see here that all the various subgroups were favored in the obinutuzumab arm, except this is female versus male. And you can see that this is just, here's the real data. The male, 66.7% had a complete renal response to placebo. And this is the obinutuzumab arm. So in the females, it was about 27% versus 47%, so about a 20% effect size. This is the safety summary. I do want to point out there were more serious adverse events in the obinutuzumab group. This is a little bit different than what we saw in the NOBILITY trial, unfortunately, but a lot of this was due apparently to running a trial during the peak of COVID. And in the box on the left, we actually did remove the patients with COVID-19 related events just to see what it would have been. And this, when we did this, it dropped the serious infections from 17% to 11%. No change in the placebo arm of about 7.6%. So much closer to what we saw in the NOBILITY trial. I'm not discounting the importance of the B-cell depleting drug in the face of a viral infection of any type, pandemic or otherwise. We do have to keep that in mind. But to me, it was remarkable that this trial made it through, given that a lot of this was during a time when doing clinical trials was quite difficult. So take that as a grain of salt. When you look at the adverse events, this is still a very potent drug, and we do have to pay attention to what we're doing to the patient's immune system, of course. A couple of interesting things. There is some neutropenia that's associated with obinutuzumab. This didn't result in any major adverse events in and of itself. It was a little bit surprising, but this is actually seen as well in the cancer patients who are treated with obinutuzumab. So that's something interesting and something to keep in mind. I have, again, used OB quite a bit and have not seen neutropenia in my own practice, but this is an N of 1 compared to a clinical trial. So something to observe and keep aware of when you're prescribing the drug in the future. We can skip over this. So these were the conclusions, but I think we don't have to go over this. We can discuss sort of what you all want to talk about now. And I will stop sharing the screen.
So thank you, Brad. That was amazing. I was also a bit surprised to see the amount of serious adverse events in the OB arm. What are your mitigation strategies actually against infectious complications in patients with lupus nephritis per se, and when you prescribe OB?
Go ahead, Anna. I'm recovering my voice.
Well, at least I have many patients enrolled in this trial, and I have no serious adverse events due to COVID. Patients, you know, in Argentina, we have to be restricted at our homes for a long period. And as soon as the vaccine appeared, everybody was vaccinated. People in Argentina love shots, love to be vaccinated. So I think that, yes, believe it or not, it's true. It's true. Luckily, it's true. And I think that perhaps something due to, of course, not I think, it's shown in the numbers, but COVID, not only infections related to COVID, because all around the world it was quite difficult to go to clinics, or to people was afraid of going to clinics during pandemic. And I think that there was a lot of things related, but not only the virus, all the panic that people had. For example, patients went to my clinic, but they were reluctant to go to take taxis or to take buses. So it was not only the problem to go and have the visits, but to being with your doctor. So I think that when what Brad said, when you analyze the drug in the real life, it's quite different. In my practice, I have no serious adverse events related with COVID. And what it's amazing is that we have no bronchitis, no pneumonia, because they were all wearing masks. So I never used less antibiotics than during the pandemic, for example.
My experience, again, using this drug and other B-cell drugs quite a bit, is that they're really well tolerated. Have not seen a lot of, sort of infectious complications yet, knock on wood. We do try to get patients vaccinated. As you know, there's some reluctance in my country right now. But we do try to get patients vaccinated when they're before we give the drug. Even if they don't develop a nice antibody response because B cells have been depleted, the vaccination also probably upregulates some things in their T cell repertoire that may be helpful as well. So we really try to push for the appropriate vaccinations before we give the drug. A lot of times we have to give the drug quickly, and so then we'll give it prior to giving the next dose of the drug. We do all the precautions that Anna said, telling the patients they're immunosuppressed, good hand washing, the usual sorts of things. And by and large, lupus patients seem to be very attuned to this, and really ours in the pandemic as well tended to do very nicely by isolation, avoiding crowds, that sort of thing. So I think this is important to, make clear to the patient because they are at risk. But I don't think it prohibits our use of the medication with the knowledge behind it.
Are there any vaccinations that you consider as mandatory? So not just nice to have. Surely we would love to have our patients receiving all their vaccinations, but some vaccination without which you would not give OB?
For those of us in the United States, that's unfortunately a bit of a loaded question these days.
Okay. Yeah.
We had plenty of people, even during the pandemic, refuse to be vaccinated with what I considered essential vaccinations. But you have to treat the patient in front of you. And, untreated lupus nephritis is really, really bad too. So, and who knows how we're going to shake out over the future in terms of vaccinations. As you well know, we have a measles mini epidemic going on in parts of our country now. But people are scrambling to get their children vaccinated again. So maybe we'll reach some sort of equilibrium.
It is not only a US problem. I heard yesterday that, especially also in Austria, 45% of people are a bit reluctant to get mandatory vaccination or, get vaccinated. So I think it's a worldwide phenomenon recovering from the pandemic that people are very skeptical about big pharma and stuff like that. It is a disaster for us, but I mean, this is, how it is.
It's the new reality,
New
unfortunately.
reality. Yeah. So one last question, I think, before we need to let you go. What do you expect for the future? I mean, B cells are an attractive target. What will be the most promising new medication coming up in lupus nephritis?
Well, obviously, the B cell therapies are very exciting because of what George Schett and colleagues have shown. To be fair and balanced, that's not completely being reproduced as the cell therapy trials are going forward, although we do see patients who are having very excellent responses. I think that it's a little bit of a B cell world right now in terms of lupus. I think the addition of a good B cell depleter like Obinutuzumab to the armamentarium will take care of lots of patients. I think our biggest challenge now is to understand which patients need which depth of B cell depletion. As Anna has pointed out, as we've gained more experience with rituximab, we clearly see a drug that has good but inferior B cell depleting properties help a lot of people in a fairly safe way. Obinutuzumab, I think, will do better than that. And then beyond that, there'll be a remaining population of patients, which if we could identify a priori would be wonderful, that will need something more. And whether that's a cell therapy or what's really exciting to me, in addition to the cell therapies, are these T cell engagers, which look like cell therapy without the cells therapy, with simply using the patient's endogenous T cells. Now, the data from the T cell engagers has been pretty small so far, right? Just a couple of case reports here and there, but there's a lot of companies that are actively working on this now. So I think that what we're going to have down the road is a menu for B cell depletion that, if we can match it to the appropriate patient population, will really allow us to fine tune how we treat lupus nephritis. The other exciting thing, and I'll just throw this out there, one of the things we've been talking about with the George Schett data is that if you had a young person who was diagnosed with lupus and had a lifetime of potential immunosuppression that's going to disrupt work, family, etc., if you could give a healthy-ish person cell therapy and they got to remain off any drugs for a long, long period of time when they were establishing their family, having their children, that sort of thing, wouldn't that be fantastic? So in other words, I'm not saying, I don't know that the cell therapies cure lupus nephritis, but certainly what we've seen now is in selected patients, they have prolonged remission off many of the drugs that would impair starting a family, that sort of thing. It would be wonderful if we could do that safely. So that would be a future that would be really good for our patient population if we see that come on board when we get more experience with cell therapies.
Yeah, I think that's a wonderful outlook. And one of the good things, it's over the counter, right? Because I mean, CAR Ts are not coming off the shelf. So I think this is really one of the better
You
things.
know that there are CAR Ts that may come off the shelf, right? There's allogeneic CAR Ts that are being tested right now, which are, to me, also very exciting, because if we can do that, that brings the therapy back more to an outpatient setting, which I think most patients would appreciate.
Yeah. So I think we are at the end of our academic hour. I would like to thank both of you, Anna and Brad, for giving us the insights of the REGENCY trial, and we are looking forward to many, many more exciting and great trials and studies from your centers. Thank you very much for having.
Pleasure.
Thank you.
Bye-bye.
Bye. Bye-bye.